It's interesting to reflect on all the developments that we've seen in breast cancer over the last 15-20 years. And over that period there's been a real emphasis on targeted therapies, on so-called biological therapies. And those have certainly changed how we treat patients with breast cancer. But the backbone of treatment for the majority of patients at some stage of their disease remains chemotherapy. So I think it's important to remember that chemotherapy remains very much at the heart of how we treat our patients. And for that reason, we need better chemotherapy drugs. So Eribulin is another chemotherapy, it's another cytotoxic. It is similar but different to many of the drugs that we previously used. The similarity is that it targets what we call the microtubules, which are the scaffold that help a cell divide, that also give a structure to a cell. And we know that that's an important target for cancer therapies because many of the existing chemotherapy drugs also target the microtubule, drugs like paclitaxel, docetaxel, the Vinca alkaloids. So it's what we consider a validated target. The difference from each of those other classes of drug is that Eribulin has a completely different chemical structure, and it interacts with the microtubules in a distinct and novel way. So it has the same target, but it interacts in a distinct way, binding to the end of the microtubule in a very avid manner, which none of the other similar agents do. So for that reason, when we first started to look at Eribulin, we didn't see it as just another Me Too cytotoxic. It isn't just another taxane, it is a member of a new chemical class. And in the laboratory, it's effective against cancers that are not sensitive to drugs like paclitaxel. So there was very strong data to suggest we should be looking at this.